welcome back. We're going to finish up today with a really important focus on healthcare in Florida and where we're going and where Florida fits into the context of the national picture, especially as it relates to Medicaid. And there's no one better to do that than former Florida Medicaid Director Beth Kidder, who's here. Yes. Florida, Beth served as Medicaid Director for the past 5 years, just recently joined Health Management Associates. She had the privilege of working with Justin Sr., who has been with us during the day, who was her predecessor as Medicaid Director as well. So without further ado, Beth, let's look at healthcare in Florida.
All right, well, good afternoon, everybody. Thank you all for being here today. This has been such a thrill to have everybody here. And as I saw people today, I know so many of you from the years that I've been working in Florida. And what I realized was that I'd seen all of you at different conferences. So I've seen you at the health plan conference or the hospital conference or the nursing home conference, and seldom seen everybody in one place. And so I think that's the purpose of this conference is to bring people from across the different sectors. But until I saw it all happen and you all hear it, it didn't really come together how important that was. And so it is wonderful that you all have spent your day here, and I hope that this will only grow over the years to be an important forum for people to share their expertise with each other so that we can continue advancing together, and also just to make connections across the different parts of healthcare. So today what I'm going to do is I've got about 200 slides, so I figured I'd just recap the last 20 years of Medicaid that I was just kidding. No. It occurred to me that as I was starting to do this that I'm not a state employee anymore, and so I don't have to be quite so slide heavy as state workers often are. But I do have a few things I want to share with you to give some context, some data and some graphs, and then we'll hit just on a couple of topic areas around the public health emergency and around the upcoming Florida Medicaid procurement, what that means for the next 5 to 6 years of Medicaid. And then I'm going to end with maybe some broader observations about how change happens and your role in it, and how we can all stay energized on that point. All right. So I'll start with a graph that these were actually, several of these were done by Vern, and I stole them from him because I thought they were so good. This one really struck me. We talked a lot about the affordability of health insurance and how important it is because people who are insured tend to get care more readily than those who don't. But this graph struck me because the line that's going up at that incredible trajectory, if you can't see the number, that's a growth rate of 284% over 20 years. And that is the cost of healthcare premiums. And if you thought, okay, well, that's unsustainable. It is. But then if you compare it to the next line down, that's earnings at 90% increase over that same time period. So it's grown at a rate 3 times faster than earnings. So that truly is unsustainable. And then compared to inflation at 60%. And so this really, I think, illustrates in one slide the challenge that we have with the cost of care and the cost of premiums for people. And where is the reality if your employer is not paying for this for you? How can you possibly afford insurance? So this is the challenge that we're talking about. So where do people get their insurance? Many of you all know this, but I think it's grounding to look at it to show that employer-sponsored insurance, although the percentage has shrunk over the years, is still over half of the insurance in the healthcare field. But the other big chunks are really Medicare and Medicaid. And so these public programs are really the affordable health insurance because they're free or lower cost for the people who get them, who qualify for them. And it's about 19% of people who have Medicare and about 25% who have Medicaid. Of course, we know you can have both. So these don't add up to 100, so don't do the math. But we're talking about 1 in 4 Americans on Medicaid. So anybody who in the past thought that Medicaid was a kind of a backwater program, I think has come to realize how central a role it's playing in our healthcare system today. And you can't talk about healthcare without talking about costs. So we're talking in the trillions. I can't even tell you how many zeros that is without writing down on paper, but it's a lot. $4.5 trillion that the US spends on healthcare, most in private insurance, which is not surprising given that over half the people are in private insurance. And then Medicare, the close second at close to $1 trillion. Again, not surprising given that you're talking about elders and people with disabilities. So that isn't surprising. But now look at Medicaid, $805 billion, about half or more of which is being funded by states. And so now we're talking about budgets that have to be balanced every year, groups that do not print dollars, as Justin Sr. used to say. You know, the federal government just prints money when they need it. States do not have that ability to do that. So these strain the budgets, and they require difficult decisions to be made between education and roads and the environment and all of the things that we want to invest in. And you always have to then look at the large healthcare costs. I'm not telling you anything you don't know, but sometimes it's helpful to just ground ourselves. So then look at the growth of Medicaid and CHIP over the last, since just 2010, and then where the trajectory where it's going. You saw a huge leap from 2010 to 2015, where the Affordable Care Act expansions started going in, and there was about a 17 percentage point increase in that time period. And since then, though, it's continued to grow, and I'll show you in a minute what it looks like during COVID for Florida. But we project that it'll continue to grow, and we'll have 92 million people in Medicaid and CHIP by 2030, which truly is just around the corner. So this is what it looks like in Florida, and most of you all have felt this or seen this, but when I was in Medicaid up until last year and the pandemic hit, and within a couple months I was saying we've got to have a weekly dashboard to see what's going on with enrollment growth, because this is out of, you know, this is out of any experience that we've had. And every week, as soon as it came into my inbox, I'd open it up and I'd wait for the week where it would slow down or it would stop or it would reverse. And it didn't. And it didn't for week after week after week. For over a year, it didn't stop, and it has not stopped. The rate of growth has slowed, but it has not stopped. So Medicaid continues to grow, and it has grown 27% since the pandemic began. And that's 1.4 million people. So we are now over 5 million, a number I've never thought I would see in Florida Medicaid. So it's extraordinary, and it is the result primarily of the continuous eligibility policies that are connected to the public health emergency. So we'll talk about that. So on Monday, we thought we might hear that the public health emergency was ending, and that would start a 60-day countdown to states having to start redeterminations of Medicaid eligibility. If you just take Florida and you think about that and say, restarting eligibilities would be a big deal even if you hadn't grown that much, because you'd have a workforce that hadn't really done so many redeterminations, and just millions of people who've not had to go through this process for several years, who've probably moved in that time, whose contact information is not up to date. What do you do with that? And now you've added 1.4 million people at a time when state workforces are some of their lowest numbers and highest numbers of vacancy nationwide, as we've seen. And so this is a really, really challenging puzzle for states to put together. And all of the states are struggling with this. They're being very creative. They're calling back retired, they have plans to call back retired eligibility workers, to bring eligibility workers who still work in the state system but maybe have moved somewhere else back in. Every possible strategy that they could think of to make this go as smoothly as possible on a moving target where you don't know the end date. You don't know your start date. So you're looking at maybe the biggest initiative that your organization has done in years, comparable to the implementation of the Affordable Care Act, and you don't know when that's going to happen. So be sympathetic to our state colleagues, please. Be kind, because they have a truly daunting task in front of them to try to do this well. But nationally, Florida Medicaid grew faster than the other state Medicaid programs around the country. Non-expansion states did see higher growth rates, but overall it was a 20% increase across the nation. And the big question is how many people are going to stay on when the public health emergency ends and those redeterminations start. So there are definitely different buckets. I hate talking about people's buckets, but groupings of people that we could see. So there are definitely people who are just no longer eligible. Their income is higher. Some of them even have other insurance coverage right now, and they just not told Medicaid that they want to get off. And that's the group to be least worried about. The others are those who are Medicaid eligible and will complete all their paperwork, and they'll stay on and they'll be redetermined. And then the group that I think people, the two groups that people are worrying about the most is those who are still Medicaid eligible, who still meet the criteria, but aren't going to finish the process for whatever reason. They don't get the notification, they don't understand, they just don't have the wherewithal to complete it, they can't get the paperwork together. All of the barriers that we know happen to Medicaid beneficiaries and create the churn that we were accustomed to seeing until eligibility was frozen in place starting in 2020. And then the other group is those that are no longer eligible, but need to then transition to some other kind of coverage. And so how do you smooth those transitions to the special open enrollment periods that the exchange will have, and other kinds of opportunities that they may have to get coverage. So this is the challenge that people are looking at and saying, you know, this is a giant event that's coming whenever it comes. And so then the question is, when is this going to happen? I would say up until about a month or so ago, most people were thinking, you know, we're going to hear in mid-May that this is ending. You know, everyone is done with COVID. We are done. We don't want it to be here anymore. We don't want to talk about it. And it's probably just time to start wrapping this up and saying we're in steady state now. We're not in crisis mode anymore. But the sentiment started to shift for lots of reasons. And then by the time we got to a couple days ago, people were saying, yeah, we're probably going to hear nothing on May 16th or May 15th from the federal government about the PHE ending, and indeed that's what happened. So the silence means that we will likely see an extension into October, mid-October, and because we're in an election cycle at that time, most likely another extension then into January. So what do we do with an extra 6 months to be more ready for this and more prepared, more aware? So I think there's a couple things to do. One thing is that I think it's incumbent on everybody to do something about this, and the reason is it's because it's in your self-interest. You could argue it's the right thing to do, but I'm gonna say it is in everybody's best interest in this room if this process goes well and smoothly, and everybody who can get redetermined does. And that is because as providers in this room, you will have patients who still need care, who will either stop coming to see you until they're in crisis because they can't afford it, or they'll come to you and then you'll be trying to figure out how to cover them, how to pay for them out of a charity care or a sliding scale or some kind of payment process. It's going to be challenging for those folks. And the other part is that as payers, for those of you who are payers yourselves, you're looking at your membership rolls dipping down, and your economies of scale getting worse. So all of these things are in your best interest to say, if people are still eligible, we should try to keep them there, and if they're not, we should try to move them on to other products where they can keep getting care. So there are a couple things. I mean, one thing is just to think about right now, when do you touch these people? When do you see them? When do you talk to them? What kinds of education could be in place? What kind of messaging could be in place when you encounter them? And when you do know where they are and you're talking to them. So that's one thing, is just sort of have that inventory and think about your plan and what you're willing and able to do to assist people, either by just giving good information, giving them a heads up that they need to be keeping an eye on this, and so on. And then once we get 60 days notice, which the federal administration has promised that they'll give us at least 60 days notice, then the countdown clock begins to start putting those plans into place, working closely with your state, who at that point will have to put in a public plan into federal CMS as to what they're doing. So their plans, if they're not clear before that, will become clear then. So, and then monitoring it as things go. As we know, they don't always go the way you think, and that we all think. So we'll be looking to see, is there data that we can keep an eye on to say, how is this going? Where do we need to adjust and pivot as we go? So I encourage you all to be thinking about that, to be working with your partners and your community partners to say, how can we work together to be unified in messaging, unified in outreach when the time comes for this to happen? All right, so now I'm going to pivot a little bit and talk about managed care and what's coming in Florida in the next couple of months. So managed care has become the dominant delivery system in Medicaid across the country. There's only a handful of states that do not have Medicaid managed care, at least at some level. And so now we're at nationally 80% of Medicaid members in managed care. That's been the percentage in Florida since we implemented statewide Medicaid managed care in 2014. So now the rest of the country is there as well. So this is the chosen delivery system. So Medicaid managed care in Florida, it's been here a long time, since the 80s in various forms, but in 2014 went to the statewide system that we know today, which has not radically shifted over the last couple of contract terms, although there have been tweaks. And what we've seen is that at each time, the Agency for Healthcare Administration has tried to advance the program further. So in the beginning, the very first term, our goal was better access, better accountability and transparency, making sure that there were enough providers who would take the members, that they were within a certain time and distance standard, that satisfaction was high, and that people were getting measurable quality outcomes, such as they're getting their checkups, they're getting their screenings, they are getting well-child visits and vaccinations, those kinds of things. And there was good progress on that in the first contract term. And then in the second contract term, when we were at ACA, we said, what can we do to build on that good foundation? How can we push the quality further? How can we have more accountability for plans for their subcontractors, and push even harder on the access standards so that everybody can get what they need? And there were so many details on that, but that's another talk, which many of you probably heard me give, so we won't talk about that. But just a couple of the goals, the quality goals that were baked into the managed care procurement last time were around reducing potentially preventable hospital events. And our thinking behind that was, okay, HEDIS measures are great. It's good to know that people are getting their checkups and their hemoglobin A1C, but a lot of these things are not really outcomes for people. So what would be meaningful to the healthcare system in terms of efficiency and effectiveness, and meaningful to individual people? And when I think of that, with all due respect to my lovely hospital colleagues here in the room, like, I don't want to be in the hospital and I don't want to go to the emergency room. That's a bad outcome most of the time. And if it could be prevented in any way, then we want to prevent that. So that's where we started to focus, and the plans have these goals to reduce these potentially preventable hospital admissions, readmissions, and ED visits. And then to work on birth outcomes, because Medicaid in Florida pays for 60% of the births, and so if Medicaid's not leading, then they're abdicating responsibilities. So, and then finally, continuing focus on long-term care to keep people in their homes, which is where they prefer to be. And so the idea behind this was that we could pick a few of these goals, we all pull together on them, and we did start to see, sometimes for the first time, all the stakeholders in the room, the health plans, ACA, community groups, and physicians, and other practitioners and providers, kind of all sitting together to say, how do we work on this? Unfortunately, a lot of that good work was interrupted by the pandemic, and so we want to keep on thinking about those areas that we can advance. So what everybody wants to know is, what is going to be ACA's focus for the third procurement? And I don't have a crystal ball, but when I thought about it, and as I think through what things will continue to be priorities, ACA says there's not really going to be anything new, but there might be some different prioritization of those. They might be in a different order of priority. But as I looked at this list, these are all the things that we've been talking about all day here. So there's really nothing new under the sun here that's not a big issue in healthcare overall. So looking at behavioral health, how can we do better? Florida has some of the worst scores in the nation on behavioral health HEDIS measures, and we can debate whether the HEDIS measures are good or bad, but being below the 25th percentile is not good, no matter how you think about it. Maternal and infant health, the potentially preventable hospital events, value-based purchasing. How do we be more effective and efficient and give some control to providers to impact the outcome at the point of care with their patients? Complex care coordination. It's one of the failures that I saw regularly was when someone had a really, really tough situation, the healthcare system mostly failed them, and people would fall through the cracks and end up in with disability or multiple hospitalizations or homelessness, all kinds of bad outcomes. We want to continue to maximize home and community-based long-term care. Extremely challenging with a workforce shortage. Extremely challenging. It's hard to keep people in their homes if no one will come to their home to help them. And then this one is a major area of focus for the agency. We don't know exactly what form it will take, but the leadership at AHCA is interested in making sure that Medicaid is, we can leverage this to help lift people out of poverty and into self-sufficiency, so that Medicaid is a safety net as opposed to a permanent way of life or your permanent insurance. And then the last two, health equity and social determinants of health. It's creeping in at the edges, and I think AHCA is trying to think about how can they start to move that direction. So these are just some of the areas. Again, these are all things that you all are working on. I'm going to touch just very briefly on health and racial equity work, and I'll be the first to say this is not my area of expertise. But I think when we think about this and we start to think, is AHCA going to focus on this? What does this mean for the next, through 2030? These next contracts are going to be through 2030, so into the next decade. It's going to be impossible to ignore social determinants and health equity. And so, this has moved from being something that was known about and cared about by I'll think about them as prophets sort of crying in the wilderness and saying, we need to pay attention to this, but being kind of lonely voices to being something that is on the lips of all the people in this room and many beyond this. So you can look at this as doing work within organizations to raise awareness, understanding, training, and getting people to know that why it's important and what to do about it. Then you can start with the external, those who actually are touching the people who are most affected, and collect data so you can really say, what do I know about my patient population? Where are the gaps that I'm seeing with this group? And then what can we start to do in an evidence-based way to get them going in the right direction, close those care gaps, get people engaged in their care, and then do the quality improvement cycle of, okay, how did that work? Let's do the next thing. And then they're doing that same work in the communities by bringing in community partners. So, one of the classic debates that we have as soon as we start talking about social determinants in Medicaid is this really Medicaid's role? Aren't we a health insurance, essentially a health insurance product? Is this our role? Is it our responsibility? And so, I think we could debate that philosophically all day long. But in the end, if you have a patient who has serious mental illness or diabetes that's uncontrolled, and they're housing insecure, they're not going to manage their healthcare condition. It's just not going to happen because they're going to be worried about a roof on their head, or the food, or where the next meal is coming from. And so it's going to face us, if we're going to keep moving the needle on quality metrics, we're going to have to partner, at a minimum, partner with other organizations where that is their job and their strength. So these are some of the ways that can be done. There is a ton of other things going on. I'm not going to go into all of this because I want to make sure we have time for discussion and questions. But what we're starting to see with social determinants and health equity is a shift towards it becoming institutionalized. And when I say that, I mean it becomes part of the fabric of federal initiatives and requirements. For example, NCQA now has a social, an equity component and certification. So when you start to see things like that, then it starts to become standard. It starts to be part of something everybody's doing, and the momentum starts to build. Certainly the Biden administration has made a large push on this and is starting to weave it into grant making. Federal grant making is going to be asking about what are you doing about equity? What are you doing about social determinants? And starting to see it in rulemaking and so on. So these are a lot of different ways on this slide that is starting to work its way into kind of standard operating practice so that we're all addressing it. And then the other place that you're seeing it, and that we're seeing it, is in Medicaid managed care procurements around the state. This is from a report we did last fall for a group, and we looked at recent managed care procurements to say, what were they saying about health equity and social determinants? What were they requiring? And I thought the most striking thing about this chart was the screening. So all the states that were looked at were saying, at a starting point, we've got to start asking the question, do you have a challenge in the area of food or housing? And then I think that the next challenge is, how does that information make its way into the kind of records that we can all work with and the kind of data sets that we all have access to? So that's another challenge, but starting by asking the questions, recording the information in a systematic way. And the other one that's really has a lot of marks in it is in the middle, moving them into quality programs. So I've talked a lot about HEDIS, but for example, you can think that you're making great strides in your breast cancer screening, for example, but then if you start to stratify your data and you look at it and you say, well, we're leaving a population behind. The averages are masking a bigger problem with the subgroup that's not getting those screenings. So starting to bake that into the quality metrics is going to be important as well. So states are starting to do that. And then another one is actually requiring the health plans who win these contracts to have staffing, actual dedicated staffing around social determinants and health equity. So these are some of the trends that we're seeing since this came out. There's been a number of other managed care procurements, so we will continue to watch those trends as we go on. Okay, so this is where I'm going to, I have lost, can I ask you, Vern, I have left some pages in my bag, which is off the stage. So this is what happens when you have a brainstorm on the way down to Tampa and decide that you want to talk about some things that were not in your slides. So I started thinking about, sometimes it can be really overwhelming, the number of problems, thank you.
There we are. I'll carry your bag for you.
Oh, thank you. And probably my water too, right now, so. Haha, the next 30 minutes of the speech, no, just kidding. But I think, I don't know if this ever happens to you, but every once in a while I get a little discouraged. And I get a little bit down about how much is left to be done, right? And sometimes it can really feel like, are we making any progress at all? And so I hope that this last bit will just give you some reasons to hope and maybe a little bit of historical perspective to keep in mind that things are getting better. Change is painfully slow, though, and it can be painfully slow. So sometimes it helps to take the longer view of it and not like geologic time, but maybe more than 5 years. The other thing is that the very polarizing and quite uncivil discourse can also make it very maybe hard to just exchange ideas with people on tough topics, and so that can be also very discouraging. But I will tell you that this has happened before in recent history. And I will take you back to 1864 during the Civil War. And these words that I'm going to read to you were things that were said by military leaders and members of Congress and other public figures at the time about the president, Abraham Lincoln. The president is an idiot. He is evidently a person of very inferior cast of character, wholly unequal to the crisis. By all odds, he is the weakest man ever elected. What to do when the existence of our country may be endangered before he can be replaced by a man of sense? This is the president that we look back on as one of our greatest of all time, right? And so it's sometimes in the moment, it is very unclear what is the right thing that is going on. So I give you that as a little piece of hope to say, and yet, despite all the terrible things that happened that time, including the assassination of that president, things did continue to progress forward and the country stayed together. The other thing, and these next points are from a book by Greg Easterbrook called It's Better Than It Looks. And this goes back to since the late 1700s and looks at some issues such as, life expectancy has increased since that time period from the age of 30 to the age of 71. So I know we're all concerned that the pandemic has dropped the life expectancy in a couple of years, but these kinds of fluctuations do happen in times of crisis and in times of war and other terrible events. But overall, we've been on an upward trajectory on life expectancy. 6% of children in the poorest part of the world die before their 5th birthday, and that is terrible. I will say, though, if you look since the late 1700s, at that time, 1/3 of children, regardless of their wealth status, died before their 5th birthday. So progress has been made there. The UN set a millennium goal of cutting global poverty in half by 2015. I had never heard of this goal. And I thought, that's crazy. It can't be done. It was achieved 5 years early ahead of schedule. And that lifted 500 million people out of extreme poverty. There was no headline about this. There was no trumpeting of this. So we have a bias towards bad news, and so sometimes we lose some of the progress that is being made in the world on the large scale. A few more things. Americans are 59% less likely than back in this time period to fall to their death. 92% less likely to die by fire. 90% less likely to drown. 95% less likely to be killed on the job. 96% less likely to be killed in a car accident. This progress is progress, but it's not in a straight line. And so I think it's the wobbles in the line that can be hard to keep in mind sometimes. One of those, for example, is on fires. So fires happened all the time and killed lots of people. One of the key things that changed in that was the introduction of a substance that helps suppress fires in building materials. That was asbestos. So asbestos caused its own set of problems that we then had to deal with in terms of damage to people's lungs and extremely serious consequences. But overall, still, people are dying less in fires, and now we're tackling the next challenge. So the line of progress kind of goes up and down, but generally is going up. So we often say we take 2 steps forward, 1 step back. Sometimes I think it's more like 5 steps back, but then maybe it's 10 steps forward sometimes. And so it's just not, a linear progression. So when we're in a period when we feel like we're taking a step back, and I'll admit that right now and during the last couple of years of the pandemic, it has felt that way. Great initiatives pushed aside, backburnered because they had to be, resources pivoted, people tired and burned out, the politics being, really unpleasant to watch or to be part of. And routine screenings are down. People are coming into healthcare. Everybody here who sees patients has said people are coming in, they're sicker, they're in crisis by the time they make it in because care routines have been disrupted, lives have been disrupted. And trust in public health and in science and in authority figures is way down. So this all feels very bad. But I think history shows that we can recover from crises like these, and we will. And that these upticks and reversals should be expected and just not to give up when you see a reversal. It's not easy or inevitable to make this progress. It gets made every single day by people like you and people like me who make micro changes, micro transactions that make a difference every day. And here's some of the ones that I've heard since I've been here today. So there's a CEO of a major health plan who takes calls from members and talks to them and doesn't shunt them off and helps them get their problems solved. There's a group that was doing member focus groups to talk to them about how they preferred to get communication about their Medicaid, and by listening to them, figured out that they were about to make make some changes to that were not favored by the people that they were trying to reach. So they listened and they learned something and they changed their process. Right now, there's a mental health awareness week going on in my 13-year-old's middle school. We didn't talk about mental health when I was in middle school. We certainly didn't talk about anybody in the family who had a substance use issue. And I'm going to wager most of our families have some, including my own. Florida Medicaid is extending postpartum coverage for a year, something that has been advocated for at least most of the 20 years I was in Medicaid. People who worked in maternal health said this is important and needs to happen. There's a provider here who is investing in a care delivery system, choosing one delivery system over another, even though the other one would be more profitable, because they don't think that's the right way to deliver care, and it's not the right thing for the person. So even though it's not as good for their bottom line, it's the right thing to do, and so that's what they're doing. And then I've heard about certified community behavioral health centers. The first ones in our state are starting to see results where we're seeing people's lives being changed. Better stability, better outcomes, better ability to function in life because they're getting the right kind of holistic treatment that's looking at the whole person. And there are 15 more that are coming online and 30 more in the process after that. And that can make a lasting change in our behavioral health system. So these are all extremely encouraging and exciting, and it's just the tip of the iceberg of what all of you are doing every day. So sometimes it's not the big sweeping initiatives. Sometimes those just, honestly, in my experience, the stars have to align for the big sweeping initiatives to happen. It's so rare. But the accumulation of all the individual choices that you're making every day, whether you're mentoring a young colleague in the field, whether you are making an efficiency, whether you are implementing a small evidence-based practice, that change comes in those small increments and it adds up over time so that, hopefully the next person giving a keynote in a couple hundred years, probably, I don't know, just directly brain to brain or something, who knows how we'll be communicating back by that time, but they'll be able to give the same kind of thing to say, look back to 2020 and 2022, it was so backwards. Since then, look at all the things that we've done and look at all the things we've accomplished and look how much better off we are despite these tough times that we've gone through along the way. So I will leave you with a favorite quote that I have that you've probably heard, but it's been something that I've had on my bulletin board for years, which is from Margaret Mead, who's a cultural anthropologist in the 20th century, which is that never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has. So thank you all for being here, and thank you all for your work, and I appreciate the opportunity to talk with you today.
Well, Beth, thank you so very much. I love the way you finished. Next year, we will have a session that's just called More Reasons for Hope.
Okay. I think we always need it, right?
Yeah, that was so good. I have a few questions, but I want to make sure that if that sparked a question or a comment in your mind, that you have a chance to do it. So the folks have a mic. Would somebody raise a hand if you would have a thought or a comment or a question? Who has a question here? Is there someone there? We have about 5 minutes left, so we have time for a question or two. I'm looking to see if, April, are you back there? Are you taking a mic to someone?
I'm here, but nobody has raised their hand
Okay,
yet.
we're not. I can't see them in the lights. So, if there is, please speak up. Beth, you were talking about these reasons for hope. You really just sparked some thoughts in my own mind. Thinking back, for example, in my wife's family, her mother was one of 11 children, 2 of whom did not survive to age 5. And that's just in the generation before my own. So we have made these tremendous strides in public health, and it's seen in the actuaries could tell us, how life expectancy has changed from our parents and from their parents to our own generation. So when you look at the things that are in the procurement, the focus has turned to these things. When you look at the Academy of Medicine and so on, and the studies show that 80% of health is related to things that are not healthcare. What we have come to know as the social determinants of health, the housing, the education, the food security, transportation, and so on and so on. So how are these things going to work as they're integrated into the delivery system of healthcare organizations?
Yeah, I think that's what everyone's challenged by, and part of it is trying to figure out what the return on investment is of that. Yeah. So we know that it impacts health, but if you're a capitated entity, you've got to balance your books as well. And so if you make these large investments, will the return come back to you? So if, for example, you help someone be housing secure, as we're seeing in the housing pilot in Medicaid, you've got serious mental illness, and you're keeping them out of the emergency department in the hospital, that might actually balance out. But what if it's something less tangible? What if it's food security? And now you don't see that immediate return. And so I think that's what everybody's grappling with, is to say, how do you recognize the need and recognize that the health outcomes are going to be impacted by that while still making the economics work when they're all not connected. So I think some of the ways that we'll have to evolve on that are thinking about value-based purchasing models or incentive models, or even the quality standards that plans are held to. Those all have to be aligned to make sure that those make sense. And then there are some models emerging in other states where part of the capitation is just being set aside for those things. Explicitly. So I think it's a period of vast experimentation right now where nobody exactly has the answer, but everyone's willing to try to do some new things. So I think we'll see some models emerge.
Yeah, there was a time, under the waivers that most states have some kind of waiver under which they operate these days, that CMS made sure that you had to focus on healthcare, and that any innovation you wanted to do had to be cost effective. You had to meet the balanced budget test for it to be approved. But now, maybe you can say a little bit more about CMS's openness to these kinds of approaches, kind of the in lieu of.
Yeah, so the in lieu of services is one way. We used to call them downward substitutions, where you could substitute one service for something that was maybe more intensive or a deeper end service. But I think there's a difference between CMS signaling willingness and then the mechanisms of how that actually works following. And so you may see, for example, that there would be a willingness to do that, but then you might see an extremely rigorous evaluation component in an 1115 that's a research protocol that's 20 pages long and extremely intensive. So I think that it remains to be seen what the willingness is good. It's a good first start to be flexible. Sometimes those things take a really long time to negotiate because CMS is trying to figure out what is their authority, what can they do. So it's promising, it's a start, but it probably is not going to lead to an overnight revolution of Medicaid coverage for these services.
A couple decades ago, you would not have had CMS even considering some of these non-medical services, and now it's almost expected that that states will build into their contracts that health plans are doing these things. Any last thing that you would like to say? We just have about 60 seconds, and then our time will be up like like the evening news. We're going to have to finish here.
Well, I think most of the people here are aware that ACA has asked for comments on the upcoming procurement, and specifically looking for innovative models in a whole laundry list of areas. And I really encourage you all to think about responding to that and putting forward, even if it's just pointing in the direction of an interesting pilot or an interesting study that you've seen, because ACA is one agency of very dedicated people, pretty understaffed, and they just don't necessarily know about all the great things that are happening out there in the world. So if you or your colleagues know about things, this is a great opportunity to kind of get some of those ideas onto the table. They may end up in the negotiations for the health plan contracts. They may end up in that, or it might just plant a seed that would blossom into some kind of pilot or innovation in a year or 2 or 3 or 4 down the line. So go ahead and plant those seeds. I had the privilege of being at ACA a long time and getting to see things that we talked about. You know, maybe it took a number of years, but sometimes with some of those conversations with some of you all, you never forget, and when the time is right, they blossom into some real change and innovation. So don't be afraid to plant those seeds.
Yeah, perfect way to finish. Let's give Beth a round of applause of thanks.